It's still morning for me. It's just 10:30 a.m. here. Haven't seen you in a long time.
We're happy to see you after so long.
Yeah. All right. So I think we'll start. So it started recording. So you just tell me about yourself and just introduce yourself. So this is Cornea Frontiers. You're welcome. It's a podcast about things related to cornea or ocular surface, contact lenses, things like that. So introduce yourself, tell us about your journey through optometry, what you're doing currently, those kind of things.
Thank you for having me. So, my name is Sushma, and I've done a master's in optometry and vision science from University of Hyderabad. And then I worked at Efficacy Institute in Banjara Hills for about 1.5 years. And then I moved to the Institute of Medical Sciences for PhD. So currently I'm working on collagen cross-linking for microbial keratitis since 2 years.
Okay. Well, thank you for that. I think maybe you might need to speak a bit louder. Can't hear you very clearly. Okay.
Can you hear me better now?
Yeah, much better. Thank you.
Okay.
The title of today's topic is basically collagen cross-linking for microbial keratitis, which is something that you're familiar with. I'm seeing that that's where your research focus is on. But before we go into using it for collagen cross-linking, could you tell us what collagen cross-linking is, basically, like an introduction to collagen cross-linking?
So in corneostoma, we have cross-linking bonds between the collagen fibers. So collagen cross-linking is a process in which we are trying to make the cornea stronger and improve its rigidity, basically biomechanical stability, by using riboflavin and UVA light, which is around 370 nanometers. So this is a procedure which is used to strengthen the corneal stability. So basically, this is used. The conventional treatment of collagen cross-linking is used in keratoconus, but there are also other indications that scientists are exploring now that can be used to treat other problems of the cornea in using collagen cross-linking.
Okay. Thank you. So for the regular or traditional collagen cross-linking, could you walk us through what that procedure is like? What is being done for the regular collagen cross-linking? How is the process done, basically?
Okay. In collagen cross-linking, we use riboflavin, which is vitamin B2, and UVA light radiation, that is 370 nanometers, 365 or 370 nanometers. So riboflavin acts as a photosensitizer. When it absorbs UV light, it releases free radicals, oxygen radicals, which helps in strengthening the cornea, which helps in forming the covalent bonds between the collagen molecules and stroma. So in keratoconus, mainly the cornea becomes thinner and cone-shaped, and the stroma becomes looser because of the less corneal cross-linkings between the collagen. So in keratoconus, we perform this procedure. As a first step, we remove the corneal epithelium. We scrape off the corneal epithelium in central around 8 to 9 millimeters, and then we instill riboflavin for around 30 minutes. Every 2 minutes once, we instill 1 drop of riboflavin, which can be either isoosmolar riboflavin or hypoosmolar riboflavin based on the thickness of the cornea. We choose if the cornea is more than 400 microns, we use isoosmolar riboflavin, and if the cornea is less than 400 microns, we use hypoosmolar riboflavin. And then after 30 minutes of instilling riboflavin onto the cornea, we place a UVA instrument, the UVA light source, which gives UVA radiation onto the eye. And we place this for around 30 minutes, which by adjusting its intensity to 3 milliwatts per centimeter square radiation. And even during the procedure, while you put a UVA light onto the riboflavin, you place riboflavin in between for every 2 minutes. so that there is more oxygen, singlet oxygen evolving that helps in corneal strengthening. So after this, the procedure is completed. You place antibiotic eye drops in the eye, place a bandage contact lens so that there won't be any infection, and patch the eye.
Okay. Well, so basically what you've described is the epi-off collagen cross-linking.
EAP of collagen cross-linking.
Yeah, so can you talk about the epi-on collagen cross-linking? What's the difference? And
the
in terms of
difference is
efficacy as well.
in terms, if the problem with epi-off is you're removing the epithelium completely, so there are chances of complications of steroid infiltrates, and it takes time to heal, and the patient will have pain for around 1 week time till the epithelium is still formed on the cornea. So people tried epithelium on cross-linking where they don't remove the epithelium, but the issue with the epithelium on cross-linking is that the riboflavin is not absorbed into the stroma well, so that there won't be much formation of oxygen singlet, so that there will be less formation of covalent bonds. So there are some studies which used iontophoresis and other procedures, so that they changed the concentrations of riboflavin and added few more things so that the penetration of riboflavin improves, but nothing very useful to the clinics as of now. So epi-off is most common.
Okay. And bringing it back to certain modifications for use in terms of management of keratoconus, for example. And I know studies haven't shown, studies show rather, that the epi-off seems to be better off in terms of the efficacy, controlling keratoconus progression better and things like that. But you mentioned using ionophoresis to improve or change the correct concentration of the riboflavin that gets to the stroma. Can you talk about that? And I know there's a couple of studies by Professor Fahad where he's looking at ways to modify basically modify the cornea. Some studies have looked at putting maybe a bandage contact lens and doing the treatment when the cornea is really thin. You mentioned ionophoresis. Are there other ways that maybe epi-on can be optimized, or maybe collagen cross-linking in thin corneas can be optimized?
So I personally do not have any experience with the experiments related to iontophoresis. Even in the studies, I have learned that they have been performed on the eyeballs, not humans, I think, as far as I know. And there is a huge small instrument that is placed over the eyeball, which has electrodes connected to it. So I really do not know if it's how safe and efficacious it is in
humans.
In humans.
Okay. And let's now bring it back to today's topic. Where are we in terms of managing microbial keratitis? For example, we know basically we look at antimicrobial agents as the standard procedure. Yeah, we culture the organism and then we find what the organism is and treat according to what the culture result shows or based on what the clinical picture looks like. I know there are some studies that have looked at using maybe steroids, at what point you should start using steroids for microbial keratitis, the Scott's clinical trial, that's the steroids for corneal ulcers trial. In terms of microbial keratitis now, aside from collagen cross-linking, would you give us sort of a brief idea of what microbial keratitis is and where we are in terms of how it's managed currently?
So in microbial keratitis, conventionally we use first line of treatment as antibiotics, broad spectrum antibiotics, till you get the results from the microbial culture and sensitivity. And once you get the results, you try to change the treatment according to the resistance and susceptibility patterns of the microbial results. And because of the increasing in antimicrobial resistance, so there is a need for alternative treatments, and that is how we thought of working on collagen cross-linking to actually surpass the problem of this antimicrobial resistance. And also by it is very difficult to produce a newer antibiotic for every 5-10 years, and it changes to every geographical location. So to tackle all these issues, we thought collagen cross-linking would be a better idea to work on and see if it's helpful in any way.
Okay, now that brings us to today's topic. How do you use collagen cross-linking for microbial keratitis? Is there any difference in terms of the protocol? For example, I know we would usually, well, standard clinical procedure would be to follow the Dresden protocol, but is there any modification to the Dresden protocol specific for when you're managing microbial keratitis, in terms of changing maybe the intensity or the concentration of riboflavin or the area you're going to debride? What are those modifications, if any?
So to understand this, we are actually working on making this protocol more defined for especially for the keratitis, because whatever Dresden protocol that we have and the instruments that we have are only for keratoconus, mainly for keratoconus. That is the idea behind making those instruments. And though ideally in keratoconus, most of the times they are little transparent when you compare with keratitis, and they do not have any infiltrates. They might have acute hydrops sometimes, but most of the times they are transparent, and the absorption capacity of that stroma is very much different from the keratitis corneal stroma. So we really do not know if these protocols would work for the same for keratitis also. There are only few studies in humans, like in the starting of the collagen cross-linking for microbial keratitis, they have done on like 30-40 patients. There are 3-4 studies with 30-40 patients, but they have included all kinds of microbial keratitis like bacterial, fungal, and acanthamoeba. So, and some of them showed that they improve the healing. They improve when they compared it with the antibiotics group, only antibiotics group, and given as an adjuvant treatment along with the antibiotics. They said that it would help in faster recovery and giving a smaller scar size, which would eventually help in better visual outcome for the patients. So there are for the accelerated protocols in keratitis, there are only like 2-3 studies which has been done, and they told that accelerated protocols work as efficacious as Dresden protocols. So there is no difference. It's just that it reduces the time. So there are some studies which show that I think it is a study from Farhad Hafizi, which says high fluence, which is like more than 5.4 joules of radiation has been used in those patients, so that it better kills the pathogens. Since the main idea in this keratitis is to avoid therapeutic penetrating keratoplasty, so that we avoid the PPK, so that this acts as an interim procedure and helps the patient. So
okay, go ahead, please.
Sorry, I think I have lost the question, or I have been going on.
So I wanted to bring you back to the procedure itself. What I wanted to know, or what I was asking was, is the intensity the same? Do you still use maybe 3 milliwatts of energy?
Yeah.
What does the accelerated CXL entail for microbial keratitis?
So we have only we have done one study from here around for 30 patients, and we have used only Dresden protocol.
Okay.
And now we realize that we need to change something, either intensity or duration, so that it works better. But the instruments itself has the less intensity, so we are trying to see if we can modify the instrument and use those protocols on in vitro and animals, and then see in human beings. Okay. So we are not sure of what kind of protocols would be helpful for keratitis.
Yeah, and I know that there are not many RCT studies that have actually looked at this. There are some, but not that many. And I did find one systematic review and meta-analysis on this topic. So looking at the area of collagen cross-linking itself, whether you're using it for patients with keratoconus, we know that around the world, it's not a cheap procedure to do. If you're going to effectively manage patients with microbial keratitis using collagen cross-linking as an adjunct to standard antimicrobials, do you think that it's going to be cost effective in the long run? Because presently, collagen cross-linking will cost a couple of $1,000 per eye, depending on what part of the world you are. But being from Africa, you're from India, you sort of see people who are on the extreme of spectrums. You have patients who are actually living in low socioeconomic environments who actually have microbial keratitis and may not be able to afford these procedures. Even the centers where the procedures may be done may not be able to afford the standard equipment for collagen cross-linking. So do you think that there is going to be a cheaper alternative? I know, again, Professor Fahad's institute is looking at slit lamp cross-linking
device on the slit lamp.
Exactly. And
CI device.
Yes, exactly, the CI device. Looking at, and I know it's cheaper compared to the standard cross-linking equipment that you would normally use. But even at that, it may not be something that may be affordable to third world countries or developing countries for practitioners or patients alike. Do you think that this is going to be a cost-effective option or way to manage microbial keratitis in the future?
Currently, we are using it as an adjuvant therapy. So we are giving it as an extra treatment. So it is an extra burden on the patient for now, that is for sure, because we are giving it along with the antibiotics. So maybe if we once understand that it is effective in a specific set of patients where the corneal thickness is this much, or where the ulcer size is this much, or where this kind of pathogen is more effective for this treatment, we might not have to give all the antibiotics. We might reduce the antibiotics and give only this treatment. So it is, we have seen some budget protocols for the microbial keratitis protocols. So it comes around $80 for a patient to treat keratitis only with an antibiotics. So if we consider that it reduces the time to heal, again it would be same. It takes less time, but the cost would be same because you are giving an extra treatment now, extra procedure, which needs most of the time the cost of the riboflavin itself is the lot of amount, most percentage of it is the cost of riboflavin in the treatment. Okay. So that is something we cannot get it down. But the UV light source, if you say, the UV light source is something which we are trying to develop at a cheaper cost, and the instruments that are available are very expensive across the world, and I think there are no Indian manufacturers also. So it is difficult. Maybe for a few years after that, if this treatment works for other indications as well, they're using it in corneal edema, post-refractive ectasia and all. So once, if this happens, that it can be used for many diseases, people might chip in and make affordable instruments that would bring the cost less. But for now, it is not cost effective.
Okay. Well, that's a very good answer. And obviously, you know your stuff. Congratulations on your ABO poster.
Thank you.
Yeah. So aside from the fact that you know it could help with collagen cross-linking can help with microbial keratitis, in the course of your research, in the course of the studies that you've had to review or the protocols you've had to go through, do you see that there is any potential complication from adding this treatment compared to just the standalone antimicrobial agents?
No, there are only few RCTs, and most of them, 90% of them, showed that the adverse events in the medications group and in the treatment with CXL device had the same number of adverse events. So again, we still have 30-40 patients as a sample size. So there is one study with fungal keratitis for around 111 patients. I think it's from Aravind, but they also did not mention that the adverse events are more in this group. They said the adverse events are same, and there is no extra advantage of using CXL in these patients.
Okay. And in terms of the microbial organism rather that's being treated, is there variation between the efficacy of CXL for bacteria versus fungi versus acanthamoeba? From what's published in studies I've seen, there are not too many that have looked at acanthamoeba, but you just mentioned one with fungi, though the sample size was quite small. But have you seen that there is a difference in the efficacy across organisms?
So if you go by literature, for bacterial, we have more studies. For fungal, I think four or five. And for acanthamoeba, like case reports, around two case series with 3 and 4 patients. So in bacteria, the results were positive. Most of the time they said it reduces the time to healing and reduces the scar size. So there is better visual outcome. And in fungal, especially in deep fungal infections, it is not very useful. It can be used for moderate ulcers only for fungal infections. And in acanthamoeba, so those are just case reports, but the results were positive. They say it is helpful.
Okay. And the cross-linking procedure itself, even if you're doing it in a clear cornea, would cause a bit of inflammation to the cornea. So when it reepithelializes, you have to place on medications. Do you, in your protocol, have to use any anti-inflammatory agents together with the antimicrobials after the cross-linking for microbial keratitis? Or are these patients post-op just using only the standard antimicrobial agents?
No, we are currently only looking at only using antimicrobial agents because the eye is already inflamed before in the infection. So we have not looked at that yet.
Okay. And looking at what from maybe experience and clinical logic, I know the Scott study, that's the steroid for corneal ulcers trial, noted that adding steroids maybe early on after maybe 48 hours of using the antimicrobial agent would help reduce the scar size if the infection wasn't caused by nocardia, that is. So looking at that as a clinician, maybe there are no studies for this, but as somebody who's been in clinics and seen patients, do you think that adding steroids early on after cross-linking together with the antimicrobial agents may have better efficacy?
This is the only study that have actually showed and became like really famous for using steroids in bacterial keratitis. But the problem is we work at a tertiary eye center, so patients come very late to us. By the time they have been using antimicrobials, antifungals and everything. So most of the times culture and sensitivity becomes negative sterile we get. And it is contraindicated in fungal infections, as we know. So if it's a mixed etiology, we might be missing out those fungal infections and be using the steroids on them. So we have not started using them yet. Maybe we need more studies like that.
Maybe animal studies first.
Yeah.
And are you familiar with I don't know if the study is still going on, but on clinicaltrials.gov, there is a study that tried to look at using oral riboflavin supplementation with sunlight exposure 15 minutes per day outdoors. I know there are some case reports that looked at that. Do you think there is any hope there?
I think I have seen this study. I think there is only one study, I think,
Yeah.
long ago, one study,
Yeah.
like single
Long.
study.
Yeah.
So it if when you compare with the direct topical antibiotics and or intracameral injections, the oral treatment would take longer to go. So we are still working at something topical and intracameral injections and all this. So it is better that we focus on this so that we act early on the infection than the oral treatment.
Okay. Now, what do you think the future for cross-linking and microbial keratitis, or maybe other applications for other corneal diseases aside from maybe keratoconus or post-refractive surgery ectasia or microbial keratitis? Do you think there are any other applications that we could use collagen cross-linking for? And what do you think the future holds for cross-linking and microbial keratitis?
In keratitis, if you say that we need better protocols, we need more studies on animals and in vitro that says these protocols are specific for this pathogen and they work for this pathogen. If we get those kind of results, that we would know that in what kind of patients to use, because once we get the inclusion and exclusion criteria better, maybe the percentage of treating them better improves. So that's why we need more animal studies and in vitro studies to understand the collagen cross-linking better in in keratitis patients. And there are few studies on corneal edema, patients with Fuchs dystrophy who has corneal edema, where endothelium is disrupted and they have inflow. They have corneal edema, and when you remove the epithelium and put riboflavin, they say that this helps in strengthening the cornea and reduces the corneal edema.
Oh, okay.
So it helps in outflux of the liquids that came into the stroma. So I think there is only one study with like 11-12 patients, and they said that it improved the corneal edema. So this is one thing that can be done other than keratitis and keratoconus. So that's all I could think of.
All right, well, that's very interesting. Wish you all the best with your PhD. Look forward to many more achievements and many more landmark research. All the best, and thank you so much for joining us today.
Yeah, thank you for having me here. Thank you.